With permission, I am starting with today's session now. Greetings and a warm welcome to all the dignitaries present here. I am Shwastika from Team Clearnet, serving as the allocated session assistant to ensure a seamless experience. Clearnet is India's most trusted and widely used digital platform, offering a multitude of enriching services exclusively for doctors. Clearnet is elated to be chosen as a digital partner for this event organized by Indian College of Anesthesiologists. So today's focus would be anesthesia non-technical skills. Let's begin today's session, for which I would like to invite Dr. Baljit sir. Over to you, sir.
Thank you so much, Ms. Shastika. Well, friends, welcome to the webinar, ICA webinar every Wednesday that's been going on for many years. And this is one of the most, I would say, looked for activity for the postgraduate students because they learn so many new things. Uh, Apart from this, the wide variety of topics which are covered by Indian College of Anesthesiologists, I don't think there's any other organization which has done it so well and for such a long period of time. Hats off to the team that is organizing, Dr. Sanish in particular, for all the activity and all the hard work that he puts into this. Today's topic is a very interesting one. Uh, all the time we discuss about anesthesia, whether it's regional, general, pain, critical care, everything. Now, this is something very different, but very, very significant. And I think this has been a overlooked kind of aspect of anesthesia. This is, they call in abbreviation as ANTS, but it is anesthesia non-technical skills. They have a lot of significance in the operating room, and I think we must acknowledge as to what their significant role is. To take this topic forward, we have a very experienced moderator, Dr. Sujata Chaudhary. She is the Additional Director General of Health Services, Directorate of Health Services, Ministry of Health and Family Welfare. One of the very senior teachers and, of course, much loved person by the students, by colleagues, for her, apart from the academic knowledge, being a very gentle and a very kind person to talk to, always very pleasant one too. So I would hand over the mic to Dr. Sujata Chaudhary, and we have three speakers which I would request her to kindly introduce as per their turn. Over to you, Dr. Sujata Chaudhary. The floor is yours.
Thank you, sir. Thank you for the kind introduction. So welcome to this webinar on ICA webinar on anesthesia non-technical skills. Non-technical skills are very important for anesthesiologists to manage complex situations like handling emergencies and working effectively with other members of the surgical team. ANTS, it is also referred as ANTS or anesthesia non-technical skills. These refer to cognitive, social, personal resource skills which complement technical expertise, contributing to patient safety and effective teamwork in the OT environment. Now, these are not directly related to the use of drug, equipment, or medical expertise. These improve interpersonal skills like effective communication, teamwork, leadership, and cognitive skills like decision making and situational awareness. So, to begin with the topic, we have our first speaker, Dr. Ranju Singh, who is well known to many anesthesiologists. She is a director, professor, and head at Lady Hardinge Medical College and Associated Hospitals, New Delhi. She will be talking about anesthesia non-technical skill, what, why, and how. Dr. Ranju. Dr. Ranju.
Thank you, ma'am. Thank you so much.
Dr. Ranju has keen interest in airway management, pediatric anesthesia, obstetric anesthesia, and life support skills. She has various awards to her credit and number of publication in international journals. So, Dr. Ranju.
Thank you, ma'am. Thank you so much for the kind introduction. Baljit sir and Sujata ma'am have already talked about how important these non-technical skills are for us as anesthesiologists. I will take you through the initial introduction and taxonomy of what actually we mean by anesthesia non-technical skills. Now, today's world there is a lot of accountability from us as doctors, and particularly in the OT environment as anesthesiologists. Everybody is looking at us through a lens, and all the professional performance is under scrutiny with actually a good aim of improving patient safety. In all this, we also need to know that the PG curriculum in anesthesia for many years has been focusing mainly on acquiring knowledge and clinical skills. This is what was told to us, and this is exactly what we are telling our PGs and residents, that you need to have effective technical skills to improve your performance and success rate in the OT. Notwithstanding this true statement, it is a definitive fact that it is the deficiencies in non-technical skills which actually increase the chance of error. There is a lot of conclusive evidence in literature which says that it is actually the non-technical skills which are responsible for increase in negative outcome whenever an adverse event takes place. There's a very interesting article published in 2016 which explored the relationship between the non-technical skills and the technical skills of the anesthesiologist and investigated the characteristics of trainees and their in a simulated unexpected difficult airway management scenario. And the authors concluded that the trainees' non-technical and technical skills were not only correlated, but rather deeply intertwined, and the interplay of both the technical skills and non-technical skills was strongly responsible for managing the patient-related outcomes. Now, what exactly are non-technical skills? Non-technical skills in anesthesia can be defined as cognitive, social, and personal resource skills that complement the technical skills and contribute to a safe and efficient task performance. They're largely divided into two broad groups. One are cognitive and mental skills, such as decision making, which are important at an individual level. And then social and interpersonal skills, such as teamwork and communication, which are important at a group level or at a team level. Now, why are we talking about non-technical skills, or NTS as they are frequently called, in the anesthesia environment particularly? We all as anesthesiologists are well aware that we work in an extremely complex, dynamic, and very often a high-risk environment. Many of us work alone, yet are required to collaborate with many other people in the OT and outside the OT. It has been shown through literature that errors during our work in the workplace, whether it is the OR or outside the OR, does not result from lack of knowledge, but results from lack of human factors. And there is also now the WHO surgical safety checklist, which emphasizes on communication and teamwork, thereby reiterating why NTS matter in anesthesia. A very brief introduction to NTS examples in anesthesia, which of course will be dealt with later in more detail, is miscommunication leading to wrong dose and drug. When you say 10 milligrams propofol de do versus 10 propofol de do, you really don't know whether you're meaning 10 milligrams or 10 ml. So it is the lack of communication which actually increases the probability of an error. Not anticipating the difficult airway by proper examination or not planning for the anticipated difficult airway is another example of NTS. Not recognizing or not communicating about early signs of deterioration that you may see in a patient is also one component of NTS. This will be dealt with later in the next talk in more detail. Now, a very interesting study published in 2018 talked about the importance of human factors in clinical practice. This systematic review talked about high-risk prone environments such as the OR and ED, and concluded that it was the absence of NTS which resulted in negative outcomes. Another interesting fact was published in 2013 regarding the fourth National Audit Project, which analyzed the major complications related to airway management during anesthesia. And in this project, it was highlighted that the human factors were responsible for the complications that occurred in most cases. And thereby, in today's world, the importance of NTS in reducing medical errors related to human factors has now been firmly recognized. Now, the NTS first started in commercially in the aviation industry. There is a lot of parallel which we draw between the aviation industry and anesthesia, and this is another, again, a common ground between the two fields. The NTS was first incorporated in the aviation industry in the cockpit. And it was later in the 1990s that the anesthesiologists in USA began to adapt the aviation crew resource management skills as an approach for anesthesia training. Later, an anesthetic crisis resource management course was organized, was formulated as part of the simulation training program, with the aim to prevent, ameliorate, and resolve critical incidents. The information gathered from these courses in the form of observations or questionnaires led to the beginning of an ANS and its incorporation in anesthesia teaching. This was followed by use of ANS and crisis resource management training at various aspects of anesthesia and related fields, in the critical care, in the operating room, in emergency medicine, and finally as a part of anesthesia education. Now, what exactly do we mean by ANS? ANS, or anesthesia non-technical skills, has a three-level hierarchy. There are four large, broad skill categories, which include 15 skill elements within each of them. The four broad categories which I will be talking about include task management, teamwork, situation awareness, and decision making. We will be in depth examining each of these four skill categories one by one. Now, the most important, or the first category, is task management. Now, task management within it has number of other skill categories. The most important among them is planning and preparation. We as anesthesiologists are very, very skilled now at planning and preparation. Whether it is primary planning, whether it is contingency planning, we do that whenever we enter the OR. We see our patients preoperatively, we do a preoperative history examination, we get our equipment ready, we get the drugs ready, and we plan the strategy for planning a case. All this is part of planning and preparation, which is a part of task management. The next skill is prioritizing. Whether it's an elective list or whether it's an emergency list, the triage and scheduling which we do with our surgeons, occasionally we do tell them that this case needs to be put up higher in the list, or occasionally when we say that this patient is diabetic and should be done first so that we can monitor them in the post-op, that's all part of the prioritizing that we do in the OT. When we take children earlier up in the list as compared to an adult patient who's on the same list, it is prioritizing the patients as needed. Lack of this prioritizing may lead to failure of allocating resources to critical areas. The next skill is providing and maintaining standards. As anesthesiologists, we are required to adhere to universal standards of good practice, treatment protocols, and guidelines. When we check drug labels, when we check our equipments repeatedly, we do a machine check before we start each case. We do a thorough checking of the blood before we start transfusion in a patient. We maintain meticulous records, particularly if there is an adverse event. These are all part of maintaining a good standard of practice. Then finally, identifying and utilizing resources. When you identify what people, equipment, time, expertise, or drugs that need to be required for a particular goal that needs to be accomplished in the theater, It is identifying and utilizing resources to meet a particular goal. So task management includes planning and preparation, prioritizing, maintaining standards, and identifying and utilizing resources. The next important skill is team management. Now, anesthesiologist does not work alone in the theater. An anesthesiologist usually works as a team along with the surgeon, along with the nursing staff, technical staff. They all form a cohesive team in the theater, and the entire team has a single goal to achieve a better patient outcome. And it is the quality of teamwork directly which influences clinical performance in anesthesia. Individual skills may be important, but the outcome of the patient is heavily dependent on the quality of teamwork in the theater. Teamwork is a skill that can be acquired, it can be developed, and this involves coordinating with other team members. There is usually one team leader or a team coordinator and other team members which are delegated a responsibility, particularly in managing a certain case. Now, the team members, along with the team leaders, must coordinate with each other to have an effective outcome. The team leader will exchange information, can use his or her authority and assertiveness in a crisis situation, should assess the capabilities of other team members and resolve conflicts constructively. This is how a coordinated team works for a better patient outcome. The key elements of effective team dynamics define how to communicate, what to communicate, and what kind of roles should be given to each team member in the team. Regarding how you should communicate or what you should communicate, it's important to understand these pillars of team dynamics. You should have clear roles and responsibilities. That is, everybody that is in the team should know what they are supposed to do. One person is responsible for administering drugs, one person is responsible for monitoring the patients, one person may be responsible for taking consent. Every person should have a clear roles and responsibilities. Every person should know what is their limitation. The team leader in particular should be aware of what the limitations of his team members are. Also, when you do a role allocation, you should be conducive to constructive intervention, particularly from the other team members in a situation where something is likely to go wrong in a high risk scenario. Knowledge sharing, summary, and re-evaluation is what defines what to communicate. Now, how to communicate includes giving clear messaging. That is, each team member or the team leader must address the other person by name, make clear eye contact, and give a clear message. There should also be a loop that should be closed so that you know that the message given to the other person has been understood. And of course, when you work as a team, particularly when it is a multidisciplinary team, mutual respect is essential to have a good outcome. The third important skill is situation awareness. What is situation awareness? It describes the ability of an individual to maintain an adequate internal representation of the environment in a complex and dynamic situation that can change in minutes or even in seconds. This includes certain skills. One of them is perception. Perception means you should be able to gather information and data from the team members to identify any problem that is occurring in the patient. For example, let's take the incidence of hemodynamic instability that can occur in a patient intraoperatively. The team leader, along with the team members, should be able to assess the trend, should be able to understand what fluid has been administered and how much blood loss during the surgery may be responsible for this fall in blood pressure. After perception comes comprehension, which involves recognizing, understanding, and interpreting this information. That is, once you've seen the trend, you've got an idea of the fluid that was administered, you should be able to understand the reason for the hemodynamic instability, try to understand the response to medication which you have either already given or are likely to give, and understand the need for further fluid and blood transfusion. Comprehension is followed by anticipation, which means you anticipate the seriousness of the situation with proper actions to mitigate whatever potential problems that are likely to occur. Will this patient require more blood? You should be aware of what the required perfusion pressure is in that particular patient. So situation awareness includes perception of the problem, comprehension of the causes which are responsible for the problem, and anticipation with proper actions to mitigate any other problems which are likely to occur. A very interesting study published in 2016 about the importance of situation awareness studied 200 cases from German anesthesia critical incidents reporting system, and it was identified by the authors that situation awareness errors were responsible in 80% of the cases. That's a mind-boggling number. And errors occur predominantly at the level of perception and comprehension. Now, the fourth important pillar is decision making. Decision making comes to us very naturally as an anesthesiologist, but it is a skill which can be learned. It's a cognitive process which involves identifying the options, balancing the risks to make an important decision, selecting the options with proper implementation, re-evaluating your decisions, and then taking a timely actions. Anesthesiologists are often faced with important decision-making points in both normal and time-pressed crisis situations. How the patient will play out in the perioperative period is a decision which the anesthesiologist makes. It is important decisions by the anesthesiologist during crisis situations, during resuscitation situations, which actually are directly responsible for the outcome of the patient. Expert and accurate decision making is thus responsible and critical for patient safety. Another important aspect of non-technical skill is communication. In fact, probably I would say it is the most important component of non-technical skill. A lack of communication or breakdown of communication is what actually creates a lot of problems within the OT, outside the OT, between colleagues, between patients and their relatives. Good communication practices will help to create trust, instill confidence, enhance patient safety, and thereby improve your own impression amongst your colleagues as well as in the patient's relatives. We do know that anesthesia is divided into three distinct phases: the preoperative evaluation, perioperative management, and postoperative care. Each phase comes with unique communication challenges and different demands. But you must remember that effective communication is vital to minimize errors, avoid complications, and tide over the crisis. Effective communication is the most important skill that can be acquired, one, through practice, and even if you observe your peers carefully trying to handle a difficult situation, you can learn a lot about communication skills. A review of 25 studies in 27 countries across 6 continents was done regarding the occurrence types, consequences, and preventability of in-hospital adverse events. And this review showed that poor communication was the cause of a majority of adverse events. Good communication with the patients can help in decreasing anxiety and pain levels and reduce complications, and will reduce the rift that occurs in the team between different people such as surgeons, anesthesiologists. It is very interesting to note that communication breakdown between surgeon and nurses is much less than between surgeons and anesthesiologists. An important aspect of non-technical skill is learning leadership skills. Leadership is the capacity of a leader to translate the vision into reality. Many times we talk about departments or organizations reaching a new high under a capable leader. I don't know how many of you are fans of our current PM, but it has often been said that he has excellent leadership qualities which have been responsible for the upliftment of the country's image in countries abroad. Now, 4 important competencies that are required for this kind of leadership include knowledge, skills, attitude, and vision. So knowledge of the mission and objectives should be clear, and the team leader should have a very clear understanding of the strengths and weaknesses of his team members. He should have the skills to analyze the situation and reach a decision. He should have the capacity to inspire others and should have the vision to achieve a particular goal that has been set forward. A good leader, therefore, not only has good knowledge and clinical skills, but should have excellent time management, communication, and organization skills. The last but most important part of non-technical skills is developing emotional intelligence. Today, emotional intelligence is appearing and emerging as a novel psychological construct in many academic, educational, and organization settings, and is now forming an integral component of the non-technical skills. It has emerged as a major contributor to safe and efficient task performance. The four integral components of emotional intelligence include self-awareness, when you're aware of your own potential, self-regulation, that is keeping your emotions control, you should not lose your temper, is what self-regulation tells you under crisis situation. Social awareness, that is particularly when you're working in a team, you should be able to understand your emotional intelligence quotient will be high if verbal and non-verbal interaction with others does not cause any rift in the team. And relationship management, when you understand the viewpoint of other members in your team. A high emotional intelligence is associated with good leadership quality, which then helps to improve the team dynamics and ultimately improve the patient outcome. So now that we've understood what the components of non-technical skills are, we've also told you that non-technical skills are not traditionally taught in anesthesia. We are moving towards a goal of incorporating non-technical skills more and more in the curriculum. But what we can do to improve non-technical skills in our own workplaces is to continue simulation-based training, team briefings and debriefings regularly in the departments, particularly after a critical incident has taken place, use of checklist, cognitive aids, and role plays with your residents to help them understand the dynamics of teamwork and other non-technical skills like communication. And finally, after you've done this, reflective practice and feedback. Dr. Akhil will be talking in detail about how to actually engage in non-technical skills and how to have an effective feedback. So to conclude, lack of non-technical skills has today consistently been responsible to be shown to be responsible for a majority of errors and adverse patient outcomes. There are growing concerns about patient safety today, which have resulted in an increased interest in the concept of NTS among anesthesiologists, and rightly so. Inclusion of NTS along with technical skills in the curriculum will definitely go a long way in improving patient outcomes. But this teaching of non-technical skills should be based on properly developed skills framework and validated measurement tools. To conclude, small quote for all of us to remember: monitors alert us to danger, but it's the communication, not alarms, that help to prevent disaster. Thank you so much for your patient listening.
Thank you, Ranju.
Thank you, ma'am.
So next we move on to our next speaker is Dr. Divya Jain, who is professor at PGIMR Chandigarh, and she'll be talking about Dr. Divya has a keen interest in airway management, pediatric anesthesia, simulation, resuscitation, and research methodology. She has various publications in national and international journals, and she'll be talking about from theory to theater, clinical applications of non-technical skills. Dr. Divya Jain. Over to Dr. Divya.
I think she's muted.
Okay, sorry for
Come on.
that.
Yeah, there she is.
Yeah, is my screen visible?
Yes.
Yes, Divya, it is.
Not coming here with the, I don't know, there's some glitch here.
We could see your CV slide, so I guess the rest of the presentation.
Even
It's coming on you.
first
It's
slide
probably
was
visible to you, no, but not to me. I don't know. Give me a second.
अभी तो blank screen आ रहा है दिव्या आगे चलो just scroll
it
ahead.
was visible earlier, Divya.
हाँ.
It was, I know. Just give me a sec.
Yes, you are visible. Your
Yeah.
screen is not visible.
I know. I stopped it. I just wanted to share it again.
You can stop your sharing once and then reshare it again. Yeah.
Yeah, I'm trying to do that. Share. Is
नहीं दिख रहा दिव्या.
okay, it's visible to me now.
Start
Maybe
sharing. Share.
Swastika can help.
Can you please?
Swastika.
What's the issue?
Yes, ma'am. Hello.
Yeah, I
She's
think
not
that
able to
Divya is
share
unable
her
to
screen.
share.
This form is not final.
Yes,
Yeah.
now it's visible, sir.
Yes.
Huh?
Yes.
Yes, now it's
Sorry
visible.
for the glitch, and thank you, Sujata ma'am.
नहीं इसके बिना feel नहीं आती है. It's okay दिव्या.
I know.
You
I
can
know.
start now. Yes, your screen is visible now.
Perfect. So, ma'am has talked elaborately on what exactly anesthesia related non-technical skills are. So, taking the discussion further from here, I will take you to a more practical thing. So, how we incorporate these non-anesthesia related non-technical skill in our day-to-day OT practice through case-based illustrations. What are the common errors which are linked to the weak non-technical skills? And most importantly, what are the barriers which we face in the implementation of non-technical skills in our OT scenarios? So let's get to the OT, the place we are familiar with. So this was a case which was posted, a 65-year-old female patient weighing 70 kgs. She was posted for laparoscopic cholecystectomy. Looked ASA1, having no comorbidities, airway unremarkable, malampatti grade 2, neck movements were adequate, thyromental distance adequate. So the senior resident was at the head end. Mask ventilation was possible, although there was some difficulty, but still it was manageable. Looking at that, the junior resident gave 4 milligram vecuronium. On laryngoscopy, Cormack-Lehan, grade 4. Attempt at intubation was unsuccessful. He starts oxygenation, but there was difficulty. He tries second attempt. Still, it was not possible. Saturation dropped to 85%. He starts screaming. He loses his cool. Give me a video laryngoscope, which was not ready. Still, we could manage to provide him a video laryngoscope. Still no view. Saturation dropped from 85 to 43%. Loses cool and attempts intubation again. Result, hypoxic cardiac arrest. So this anesthetist, the senior resident who was at the head end, was actually not a bad anesthetist. Technically, if we speak of what we have been told, he knew how to intubate. It was just that the patient was difficult. He knew how to use a video laryngoscope. He knew the algorithm well. Despite that, this adverse event happened. So what went wrong? So what studies have shown that up to 70% of anesthesia-related adverse events are due to human factors. That is, lack of non-technical skills and not technical incompetencies. So ma'am has just talked what non-technical skills are about. It is an amalgamation of cognitive, social, and personal resource skills that help to save the patient or help us to give a safe anesthesia, if I say. So cognitive skills basically broadly divided again into individual and the team related skills. The leader or the team leader, whosoever should be actually should try to maintain his cool so that he can make a proper decision, be aware of the situation and solve the problem. Along with that, communicate well with the team and show some leadership qualities. So what were the things which were missing in our case? Situation awareness, was it there? He knew that the oxygenation, this mask ventilation could be difficult. But was the team aware of the situation? No, because that was not communicated. There was lack of communication. Decision making. No call for help. He knew that he was good at technically with his skills. So he continued doing the skills himself. That can be a fixation error or anything, but you do not call for help. That is poor decision making on the part of the leader who is standing at the head end. Team dynamics. He was not the only person in the OT. There was the OT staff, there was a nurse, there was a technician, but there was a surgeon who could have helped him, but no one was called, no one was communicated. There was no delegation of roles, no role allocation was done. Most importantly, what I feel, he was not trained to handle that stress which comes under pressure. So which led to all this confusion. So as ma'am had already highlighted, the National Audit Project, which is one of the biggest report which has been done on difficult airway, out of 1 lakh cases which were reported, which were studied there, 184 serious complications, airway complications had been reported. And the most important culprit there was found to be these human factors or the non-technical skills, which ranged from 4.5 per case, which is a huge number. So let's redo the situation which we did. What lapses happened? Let's see if we can improve them. So this was the same case which was taken. In the similar scenario where it was an unanticipated. So probably it was prepared just as a routine case. Induction, all monitors, pre-oxygenation is good. The person at the head end shouts, I'm ready to start. So there is situation. The team is briefed that pre-oxygenation has been done well. The monitors have been attached and they set the expectations that the induction process can now start. So it's basically getting everyone on the same page. He attempts a laryngoscopy. All the induction is started. The drugs are given, but he gets grade 4, Cormac-Lehan. So he calls for the JR, calls the senior consultant for the help and get the video laryngoscope ready. So this is, he showed the quality of leadership there. Being the senior most there, he took the decision that he needs someone more senior to him there and made a proper decision. There was flexibility. He asked for a change in tool. The senior consultant came. We tried video laryngoscope, failed. Tries to oxygenation, asked for LMA. LMA was not available. So he quickly, without wasting time, Kiko declared, I can't intubate and ventilate, and ventilation is deteriorating. So plan for front of neck access. So this is clear leadership on the part of the consultant. There is clear message which was given for call for help. So next, he asked the resident to arrange for a scalpel tracheostomy kit immediately. Alerts the surgeon for a emergency tracheostomy. The nurse is asked to prepare the neck. So this is proper task management. The surgeon at the head end asks, scalpel ready, team, I need a head neck extension and some local infiltration. So there is a good communication which is maintained between the surgeon and the anesthetist. Bougie has been passed. The cuffed endotracheal tube has been inserted. Please confirm through capnograph. Again, there is a situation awareness, making the people aware that RICO has been done and we want to see the results. A proper decision making of front to neck access has been made. So this is what we call as a good communication, a good teamwork was done. What was the result? The patient was stabilized with SpO2 96%, and everyone applauds for a great work. So what was different in this case than our previous case? Here we had a leader who had a clear mind. He could think calmly, not get carried away with a stressful situation. He anticipated what wrong was going to come next and prepared. He recognized those early signs and acted preemptively. He used the entire team, the nurse, the surgeon, the residents, for proper knowing their capacities, and the roles were allocated. So this is what makes you from a good technical anesthetist to a great anesthetist. The skills that make a difference between a good and a great one, especially when the things go wrong, are these NTS skills, or the non-technical skills, what we call. Let's take another scenario. So the induction from for anesthesia had started. So in the early phase, you give the antibiotic, Taxim injection. Taxim was given 15 minutes after the injection. There was flushing, there was urticaria. Sudden hypotension was noted and the BP dropped down. There was bronchospasm and the airway pressure started rising. There was a senior resident who was standing at the head end. He immediately shouted, "Team, there is flushing and hypotension, which suggests that there is anaphylaxis. Mobilize the resources, get a crash cart ready, and prepare for epinephrine." So this is what you call as early recognition. This is what is called as maintaining, being aware of the situation and making everyone come on the same page. The resuscitation process begins. Anesthesia nurse is asked to give IV fluids 500 ml crystalloid. She responds saying that this has been started. Junior resident, draw up and administer 100 mics epinephrine IV push. He responds saying that has been started, sir. Anesthesia technician, continue monitoring BP and alert me every 30 seconds. Alert me if there are any changes. This is how you delegate the responsibilities depending upon the skill of each and every person. A proper task management is done. And the result is you regain the control. The BP starts rising to 100 by 60. The airway pressure starts normalizing. So at that stage, the resident shouts, "Keep running the fluids. Let's maintain the epinephrine infusion and update me every minute." So a proper team communication is maintained at all stages. So this is what is called as proper having those non-technical along with your technical knowledge in place. So this is an ideal recipe to avert any crisis. Having a calm mind, showing some leadership capabilities, and not letting and maintaining a good communication at all stages, being aware and keeping everyone on the same page, making everyone aware of the situation, and having a good teamwork and a mutual support of each one. In this way, you can avert majority of the crises which happen in the OT every day. But intraoperatively, is that the only phase where we face such kind of issues? No. As ma'am said, the anesthesia practice runs from pre-operative to the post-operative period. And these non-technical skills should be ingrained in us, that we start our day using both our technical knowledge and those non-technical skills together. In the pre-operative area time, when we start the case, the WHO checklist is one of the primary examples of a very good example of the display of the non-technical skills among anesthetists. If you have a difficult airway case in your OT, if you have a case who's high risk for PONV, what do? You plan among them, you make a plan A, B, and a backup plan. So this planning strategy, having everyone being aware of this situation, that this is the problem which you can face and how to avert it, making a plan and communicating with each other, is what we call as non-technical skills in the preoperative phase. Intraoperatively, we have just seen these scenarios. Having intraoperative, if you have any crisis, be it a difficult airway, anaphylaxis, can be averted through good communication, good teamwork, having a leader and not a boss. And in the post-operative, this runs through even in the post-operative period when you give the handover. So handover is another component of non-technical skills where you tell the sister in charge in the PACU what exactly was the management in any adverse event which happened, how much pain relief, what exactly needs to be given in the so the sister needs to be on the same page again to know what exactly needs to be given in the post-operative period, again to avoid any complications happening in the post-operative phase. So if you look at the WHO checklist closely, it has got 3 phases: the sign-in, the timeout, and the sign-out phase. In the sign-in phase, what happens? You confirm the patient's identity, you ask about the allergies, the airway risk, and discuss the anesthetic plan. So what is there? You are communicating, making the people aware of the situation. Then you have the timeout phase, where you confirm again the identity, the site, the procedure with the team. Highlight the special considerations if there are any. Again, whosoever is speaking is showing some leadership and you share a common mental model. Once the case is over, you review the fluid balance, what were the medications given, hand over the patient's pain management to the PACU team, flag any complications or monitoring which is needed in the PACU. Again, this communication in the entire perioperative period is extremely important to prevent any adverse event which can happen. So NTS errors, despite maintaining good technical skills, there are errors which we have seen, which happen in the OT every day. Why? Because of the lack of communication. The task execution is not done and a poor decision-making happens. And what is compromised is the patient safety. So this was article which I'm highlighting again, which was, it is basically a German audit, which was done of 200 cases, which showed that almost 80% of the critical events had situation awareness errors, which is a big number. So this was just about the situation awareness errors we are talking about. If we take into consideration the communication errors, the team dynamic errors, it's going to be almost 99.9%. So this is why we say it's basically the human or the non-technical skills, the lack of non-technical skills, which land us as an anesthetist in situations which are untoward. How many times when you are working in the ICU, we have seen missed desaturations? Why? Because there was loud alarms which were running all over. So this is lack of situation awareness. You have a high-risk case, but the JR has not prepared the vasopressors. This is failure of planning and awareness. There is an anaphylaxis which is happening in the OT. But you seem to be confident, you have a fixation that you can manage, and you do not call your senior. This is communication failure. Repeated attempts to intubation. And you keep on doing the same thing again and again without change of hands, without change of equipment. What happens? So what is the consequence? Consequence can be anything. Delayed treatment, intraoperative hypotension, team being unprepared, or the patient landing up in hypoxia. All this is, but what is the end result? The compromised patient safety. So whatever technical skills we have been in our curriculum, we have been the emphasis has been so much on the technical skills that somehow the importance of this non-technical skill is still yet to be highlighted in our curriculum. Why? Because there are a lot of barriers which we face in implementing these things in our routine day-to-day work. What are the barriers and how do we overcome? Most important, the hierarchical system which we have in our. Then the disruptive behavior is there. And third, the cognitive issues. So let's see how you can overcome these barriers to have good team dynamics and still maintain your cool and work in those adverse situations. hierarchical situation, what have we been taught? That the boss is always right. But what is the problem with that? The problem is that we do not actually need a boss in the OT. What we need is a good leader. So what is needed, what is the thing which is required nowadays is flattening this hierarchy. And this can only be done if we have good leaders who can lead the team. It's not that the hierarchy can go off. Maintain a clear hierarchy, but respect the other team members. Let them speak. So for this, you need to create an inclusive atmosphere where the residents can even share. They know, depending upon their capabilities, you allocate their resources and make the best use of the team which you have. You take the entire team with you and develop that speak up culture. For this, it's not the training only of the residents, but of the mentors also, not just the mentees, but the mentors also is needed to develop a effective speak up culture. How many times have we faced this disruptive behavior? If you look at the literature, this was an interesting article which I came across, which showed that 6 to 18% of the clinicians are disruptive, but almost 98% of us face this disruptive behavior. So this disruptive behavior is one of the biggest barriers which come in the way of good team. Because a person who has a fixed idea that he can do the things on his own, he gets irritated. It's difficult for us to work with him as a team. So what is the solution to this? These solutions cannot be dealt just at the micro level, but need to be dealt at the macro level as well. Macro level, by macro level, I mean at the institutions. So the institutions or the workplaces, all a proper standards for working standards should be maintained, and there should be something to monitor the compliance, that people obey those or keep up to those standards. These standards should be enforced, and people who are not obeying should be remediated for that. At the micro level, any person who faces this disruptive behavior, the victims, the witnesses, should come forward, appraise about the situation so proper corrective measures can be taken. Last but not the least is the cognitive overload which happens. We all have worked as anesthetists in situations which are high catecholamine. When we get other high catecholamine surge, high adrenergic derives, the patient is sinking and your BP is rising. So what happens? The brain stops functioning and you start functioning at the spinal level. So how do you tide over that situations? How you can handle that cognitive stress which happens in adverse situations? The use of cognitive aids. So if you have those protocols, the checklists, the decision trees in place, then the things get imbibed just at your spinal level. Even if when this situations like the patient having a difficult airway or intraoperative anaphylaxis or anything like that happens in the OT, you can tide over if you know, because it's even at your spinal level, you know what is the next step which has to be followed. But even if you forget, you have your team there, you know, a proper communication. And if you have developed that speak up culture, if you have missed something, your team member can easily point that out to you. So this is how a team can work. The pressure is not taken by one person, but the entire team members. There is prioritization of tasks. Do not take everything to yourself. I can do the laryngoscopy. I can do the video laryngoscopy. I can manage the cricothyroid. So in crisis situation, you will not be able to manage anything. So prioritize your task. Ask the people who are more efficient in it, delegate the task to them and let them handle the situation there and then. For this, what we need is a proper training, and there can be nothing better than simulation, which can help us to learn these non-technical skills. As I already told you, our training has basically been concentrated on teaching the technical skills, how to intubate, how to put a spinal, how to put an epidural. But what we need to realize is the NTS skills are not optional. They are very important and should be imbibed for the patient safety. Thank you. I think I have kept it short and crisp just to make people emphasize that how interoperatively, not lack of these skills, can make a difference in the OT scenarios. And I'm sorry about the technical glitch which happened at the start.
Thank you, Divya. Thank you very much. So now we move on to the third speaker. And our next speaker is Dr. Akhil Kant Singh, who is an additional professor at Anesthesiology, Pain Medicine and Critical Care, AIMS, New Delhi. And Dr. Akhil Kant.
Yes, ma'am.
Can you show us your slide?
Yes, ma'am.
So Dr. Akhil Kant is working as additional professor at AIMS, New Delhi.
Can you see my screen, ma'am?
Yes, yes,
Okay.
it is. And he'll be talking about measuring the intangibles,
Right.
assessment and documentation of non-technical skills. So Dr. Akhil
Thank you,
Kant,
ma'am.
over.
Thank you, ma'am. Good evening, everyone. It's my pleasure to present this very important topic. I believe it's a very important topic, and I'm sure the previous two speakers have emphasized the importance of why we need to teach and impart these skills. And I'll be basically talking about how are we observing and documenting these non-technical skills. So we've already covered why should we focus on non-technical skills. I'll be briefly talking about the ANTS framework and how we're going to observe NTS in the clinical settings in our daily routine work. Where does simulation come in to help us develop these non-technical skills in ourselves and our students? And how do we document them? And what are the challenges and tips which are frequently faced by people who actually practice these NTS skill education? So the emphasis on non-technical skills in anesthesiology stems from the critical role these skills play. Like Ranju madam already mentioned, that a lot of our practice, especially with regards to non-technical skills, come from the aviation field. And anesthesia has always been on the forefront of adopting these cutting-edge technologies and educational techniques into anesthesia. And I believe it has held us in good stead till now. So, yeah. So the basic idea is that since we are working in an OR environment which has multiple professionals, the anesthesiologists, the surgical colleagues, the nursing staff, the paramedical staff, working in close proximity, all with the simple goal, the shared goal of improving patient outcomes. Since you have a multidisciplinary team involvement, human factors always come into play. And how to harness these human factors and prevent them from becoming hurdles in good patient outcomes. That's what non-technical skills is all about. So, like I mentioned, human factors have already been implicated in a significant portion of anesthetic errors. Understanding these factors helps us mitigate risk and enhance safety by addressing the root causes of these errors. So, this all started in the year 1999 when a group in Scotland, as part of the NHS system, thought about inculcating these NTS behaviors into anesthesia, taking inspiration from the aviation field. And they basically looked at what are the skills involved in communication, teamwork, what improves decision making in close teams, and how does the situational awareness of the environment affect these decision-making skills and the communication skills as well. So when we talk about NTS, like Madam already said, we'll basically covering these four domains: skills, communication skills, teamwork, decision-making, and situational awareness. So the ANTS framework provides a structured approach for assessing non-technical skills in anesthesia, helps in identifying specific areas of improvement, because only when you know what you want to improve can you actually improve. Otherwise, it's like shooting in the dark at a blackened target, not knowing whether you've actually hit the target or not. So the development started in 1999. The paper came out in the British Journal of Anesthesia in 2003 by Fletcher et al. They basically designed this framework to assess non-technical skills And they described the process of adopting this framework into their anesthesia training program. They also, if you go through that paper, that's a very nice, it's basically a short review about the entire process, which lasted for around 4 years, from the inception of the idea to the actual execution, how they went about enrolling 50 anesthesiologists and asking them what were the important non-technical skills according to them. And then they had sort of a consensus process, after which they came to around 15 4 domains and 15 subdomains, uh, on which people were assessed, their residents were assessed, whether they had good technical skills or where they could improve when it comes to non-technical skills. So like I said, 4 domains. These 4 domains are task management, team working, situational awareness, and decision making. These are further divided into a total of 15 subdomains. This has basically been covered, but what was important was that they basically concretized this framework. At the same time, they also provided behavioral markers. Now, what are behavioral markers? Behavioral markers are basically examples, so that it basically gives you an idea, the observer an idea about what they have to look out for. Otherwise, if you tell a resident trainee that you did not plan well, that's a very subjective observation. It does not help neither the trainee nor the observer at by telling them what they're actually looking out for, what they have to improve upon for. So these behavioral markers basically give you an idea about what you have to look out for. So observing non-technical skills in clinical settings, again, that's the basic crux of the entire framework. It's well and good to identify domains and identify fields where you have to improve upon or where you have to observe upon. But how do you actually go about observing these non-technical skills? It's that is the basic crux of the entire exercise. Unless you provide the observer and the trainee observable behaviors, then they will not be able to improve otherwise. So what are observable behaviors? Observable behaviors, this again, it comes down to subjective impressions versus objective assessment. Like I mentioned previously, if you tell a resident that you do not plan appropriately for a placenta accreta surgery, for example. Now, the resident understands that he or she did not do what they were supposed to do, but unless you tell them what exactly they should have done or what exactly they could improve upon next time, you lose an opportunity, a learning opportunity, a training opportunity. So instead of saying that you did not plan appropriately, if an observer tells them that since this is a placenta preta case and you would expect massive blood loss in this patient, so were you able to cross match blood units and other blood products adequately? And then that gives the trainee an idea, okay, so I have to look after the blood management because this is a patient where I would expect a lot of blood loss. So I have to anticipate that problem and plan for it. So that gives the trainee an actionable insight. Next time if I have an Akrita case, I have to think about patient blood management and plan appropriately. So whenever you're trying any exercise, exactly, I mean, it's not just limited to NTS. I believe if whenever we're giving feedback to anyone, whether it's a trainee or whether it's our colleague, if you really want to help someone, you have to give them short insights about what they can improve on. Obviously, the way you say it is going to differ whether it's a trainee or whether it's a colleague. But you can always say, this is a Krita case. I would have definitely planned for blood transfusions. Maybe get a large bore IV too, or maybe get a sheath inside if if I was anticipating a lot of blood loss. So rather than just saying like I could have planned better next time, that is not helpful. Giving actionable insights is always more helpful. So when we talk about NTS in practice, real life scenarios always benefit from NTS assessments and feedback based on NTS as well. So examples would include that, how do you practice effective communication in a team? Divya ma'am said that, NTS does not end when the patient is wheeled out of the OR. It also continues during handovers in the post-op area, for example. Suppose your patient has a allergy to NSAIDs. I am sure everyone will agree that this is an important piece of information to share in the post-op area as well. So the PACU team needs to know that this patient has a NSAID allergy. So communication plays an important part there. Prevents problems. You have to anticipate problems and prevent them. So now we know what is the importance of ants. We know how is it important, where are all the problems which we can anticipate and improve upon. But I mean, करते कैसे हैं, that is the bottom line. ये सब तो ठीक है, all this is well and good, but how do you actually go about implementing this in practice? So thanks to Fletcher et al. And Gaba et al. After them, there have been multiple iterations of different frameworks, different assessments of ants frameworks. So one is not necessarily better than the other, and it's a work in progress. It's been more than 20 plus years, and there are still papers coming out on ants, the benefits, and how you go about assessing them. So it's a work in progress. But the idea is that you have to have some form of, doesn't matter what form, but some form of standardized assessment, which everyone can agree upon and which everyone can get trained upon. It's not just the trainee whose training is important. It's also the ants observer whose training is important, because you want to make sure that the feedback you're giving is appropriate and is helpful. It's a losing battle if you start off with, like we always talk about in simulation, that it has to be psychologically safe. So if your feedback is psychologically unsafe, you're losing a training opportunity and you're preventing your trainee from approaching you in the future if they have a problem. And like ma'am said, you're talking about hierarchy. Hierarchy is the enemy of good teamwork, right? Hierarchy is important in some aspects, but if there is too much of hierarchy, if your trainee is not able to approach you, or if your colleague is not able to approach you and point out an error or ask a question at the right time, then that creates problems later on. So standardized assessment is important. Consistent documentation. If you have a standardized assessment form which you're filling during your ANTS assessment, whether it is during a real life scenario after a difficult case, for example, or during a simulation scenario, if you have it documented, it serves two purposes. One is obviously you can use that immediately after the scenario or the case and talk about it with your trainee. Also, it allows for sort of a record keeping. If you're looking after, if you're doing this as a regular part of your formative assessment of in your residency training, you can go back to these documentations, go back to this record and say whether your training program is effective in improving NTS, right? If you have a trainee who is consistently improving his NTS assessment throughout the 3 or 4 years of training, then you have confidence in your training program. It can also tell you where you need to improve as a trainer, not just a trainee. Where you can improve on your teaching as well, and it also gives you feedback from your trainee. Yes, you said this, but I have done the same case with another faculty or another consultant, and they do it that way. So, am I wrong in doing that? Then you can have a start of a seed of a discussion and see where that goes. So, again, I believe simulation is a very still underutilized technique, which we should incorporate more into our practice. So, I'm sure most of the people who are listening, probably at least the faculty, I can say confidently, are also part of the same group. So I'll be preaching to the choir when I say that simulation is important quiver in a arrow when it comes to medical education. And with regards to non-technical skills, it's an extremely important arrow as well. Why? Because it provides a realistic training environment. It's always, obviously, as you can imagine, in our busy OR schedules, it's not always possible to, when you, especially if you have a rapid turnover, that you have a debrief time immediately after a case or between cases. It's not always feasible. So if you have some standalone simulation time, you have a couple of trainees with you. You can always run scenarios You can talk about your technical skills also, that's important, obviously, but you can also talk about your non-technical skills, something which I believe we do not pay enough importance to because of the hierarchy, because of a lot of resistance from the old guard, if I can say that. Using simulation also enhances confidence, right? If suppose you obviously would prefer a resident to have some experience with managing complicated cases or managing complicated emergencies rather than pushing them into the deep end and hoping that they float or swim, right? So if you give them opportunities to practice these skills beforehand, before they actually employ these skills on a real life patient, enhances confidence. And especially in our setup, where we do not give enough importance to non-technical skills yet. So employing simulation can develop non-technical skills, not just assess them, but develop them as well. So, like Madam already said, that there is ample evidence of improvement in non-technical skills with assessments, with using simulations, leads to enhanced performance in real life scenarios. And there is a decent body of research evidence which points towards this as well. So I think we have enough justification to employ this in our day-to-day practice. The question is, how do you do it, right? So as an example, quickly, I would like to just go through, suppose an example of an intraoperative anaphylaxis. Suppose you had a patient who's going a lap chole. You gave, after standard induction, you gave a dose of atracurium, 30 milligrams. And you notice that maybe 30 seconds or 1 minute later, after giving the atracurium, the patient develops redness on the forehead. There is tachycardia, there is hypotension, right? So what do you do? Where does non-technical skill come into the picture here? So task management, right? If you quickly go through the 4 domains of NTS, task management. If a resident asks to stop all possible triggers immediately, oftentimes there is antibiotic also going in before the incision is given. You want to get the antibiotic in before the incision is given. So stop the antibiotic, initiates anaphylaxis protocol, starts giving fluid, teamwork, instructs the nurse to prepare adrenaline, or ask the surgeon to stop. If they were planning to, put the trocar in, ask them to stop. Tell them that what's going on. There is hypotension. I think this is anaphylaxis, possibly due to an atracurium bolus. So please stop. I'll let you know when to proceed. Do you anticipate hypertension? Do you recognize your rash early? Do you anticipate bronchospasm? This is a possible anaphylaxis. As part of anaphylaxis, patients often have bronchospasm. So should I ask my resident to get the salbutamol inhaler? Get the adrenaline ready. Decision making. Ask for help if required in time. Postpone surgery if the patient is unstable, or ask the surgeon to wait if you think that you can stabilize and may get the surgery done. So all these are aspects of non-technical skills. We're not talking about doses of adrenaline. We're not talking about airway management, but we are talking about anticipating problems, working as a team, task assignment. Do not ask your first year resident to prepare drugs if you think that they do not know how to. Like this is July, right? Once the vacation ends, we'll be beginning ORs. So invariably, I'll have a 1-week-old resident with me. So it will be foolish of me if I ask them to prepare adrenaline if they don't know how to. So anticipate trouble, know your team, and assign tasks appropriately. So that's just an example of how NTS works, right? So how do you incorporate this into training? So we have, I mean, all of us, many of us come from training programs, and we have good caseloads. We have smart residents coming into our program. So it's not a problem of, the residents' intellect. I mean, I always tell my colleagues that the importance of, we are quick to scold our residents. इसको ये नहीं आता है बेटा, but उसको इसलिए नहीं आता है because you've been doing this for 20 plus years, he's been doing this for maybe 1 week, okay, or 1 month. Obviously his level of knowledge is far lower as compared to yours, but it's only a matter of time, not a matter of intellect. So if you incorporate ants into your residency program, I assure you, technical skills apart, this will only lead to better patient outcomes. Obviously, we are in the process of generating evidence that improves patient outcomes. It's a different ballgame altogether, a very difficult task to do, but it should be a part of a comprehensive anesthesia training program in this day and age. That's my opinion. Obviously, when you go into practice, when our residents go into practice, they will be on their own. They will not have the shield of a consultant to take the blame for problems. They will have to work in a team along with the rest of the colleagues, the surgical colleagues, the nursing colleagues. So it's important because it helps to enhance communication skills. So incorporating these skill training, this and training into your residency curricula makes for the making of a more well-rounded anesthesiologist. So when you talk about simulation and ants, so just the utilization of an ants framework. Suppose you, I showed you the feedback form, the ants framework form with the 4 subdomains and the multiple subdomains. Even if you do not have opportunities to debrief, ideally you should have debrief opportunities. You should have feedback opportunities to and fro from the resident and to the resident. But even if you don't do that, if you just give them this form and help them fill it, what you could have done, what you couldn't have done, give them behavioral markers, and they will be able to fill it themselves. Even if they do not talk to you after filling this, it gives them a reflection opportunity. This is what is expected out of me in this particular case, and how well did I do during this case. That in itself is a win. If you are able to have a full debrief, talk to your residents, talk to your colleagues after the case is done, more power to you. That's the way it should be done. But even just getting the form filled and giving it to them to think about it, that's a good starting point. So documentation. So we have these and score sheets freely available on the internet. I'll be happy to mail them to whoever wants it as well if they're not able to get it online. Helps in documenting, helps in record keeping, provides for a standardized evaluation. Uh, not just for your own records, also for the residents. If they are able to do this maybe once a week, go through the ANTS framework, think about it on their own, have some time for reflection, you will see that they are able to incorporate and think about ants even when they're going through their daily motions of a case. And that in itself is incorporating ants into your daily practice. It doesn't have to be a formal assessment, just that filling the form, thinking about it. And I encourage everyone around me to just do it on their own. You don't even have to, ask someone to assess you. If you have that form, think about it and go through it. Maybe you will find a point or two to improve upon next time. So documentation is obviously important, helps to monitor development, and obviously helps to assess how effective our training program is in helping the resident achieve the full potential. What are the challenges and tips which you can help to improve our ANTS implementation? So the biggest problem in the literature and which we have also encountered during our implementation of ANTS is that there is a lot of subjectivity involved. If an observer is not well trained in assessing the ANTS framework, a lot of subjectivity can seep into our assessments. And obviously, subjectivity is not a great thing to do. You want to keep it as objective as possible every time, whenever we are doing it. That's why we are moving from long answer questions to multiple choice questions, right? Because we're trying to remove the subjectivity out of the assessment. It makes for an easier assessment and makes for a I won't say bias free, but I would say less biased assessment of our trainees, of our programs. Okay, it also gives you a clear assessment criteria, not just to the observer, but also to the trainee. They also know that this is what I'm being assessed upon. This is not a black box that, the observer, I don't know what the observer is thinking when they are assessing me. These are the 4 domains. This is what is expected out of me, and this is what I have to do to improve upon my performance. So this is this is the biggest hurdle when it comes to ANT's framework implementation. Subjectivity, driving out the subjectivity out of the observers is the biggest problem. Now, obviously, ANT framework is a relatively newer concept. 20 years is not, I mean, I'm sure I would be able to find at least 10 people in the audience who would have heard about ants for the first time today. So therein lies a challenge because it's not a very well-known concept. And because it's not well known, so people are not well versed with it. And that is true for observers also. It's not just that they need training, they also need frequent corrections, because it's very easy for the bias, for the subjectivity to creep in. You need well-trained observers who have to be given constructive feedback. Again, constructive feedback is always important, not just for the trainee, also for your observers. You need to tell them exactly where they need to improve upon. Okay, so this is the biggest hurdle for ANTS adoption across the world. This is a fact which has been accepted by Fletcher et al. Also, that in the original paper, if you see that they during the pilot induction of this program, they identified two programs, one in Scotland, one in Manchester. The people in Scotland refused to adopt this program because it seemed to be too daunting. Only the program in Manchester said that, yes, we'll go ahead with it. So therein, when the initial adoption itself had problems, there you can imagine that there has been some resistance to its adoption. But slowly we're getting there with more people believing in this concept and adopting it. So importance of regular calibration cannot be overstated. This is true for any kind of assessment. This is true for simulation also. When we are talking about debriefing of the assessment of the debriefers, training of the debriefers is as important as the assessment of the trainee or the simulation participants. So only because your simulation scenario or your ANTS assessment is only as good as your observer or your assessor is. So there has to be regular calibration of your observer. You need to provide opportunities for your trainee to discuss what went wrong, what could have been done better, what went well during each session. It cannot be a one-way didactic session. I'm giving a lecture, you listen, and then you go home. That's not the way it works. And obviously, the management, the leadership of your program, and the people who are actually executing the ANTS framework assessment have to be on board to see what are your educational goals, because then only will you have a successful adoption of the program. So in conclusion, NTS, non-technical skills are crucial. They are absolutely crucial, and they are non-negotiable in today's anesthesia practice. Observed, trained, and documented, and each aspect is very equally important. Also, use ANTS framework to structure assessments and feedback. You can say this is something that you need to improve upon, and go and improve it, and then come back and assess it again. That's how you improve. Finally, this is an important adage, which is true for all medical education. What gets measured gets improved. What does not get measured cannot improve. Thank you for your time and attention. I'll be happy to take any questions at the end. Thank you.
Thank you, Dr. Akhil Kant.
Just
So
trying
to
to
summarize,
stop my screen sharing now. Yes, ma'am. Can you hear me, ma'am?
so yes, all the speakers, they did a very good job. And to summarize the topic which we discussed today was the anesthesia non-technical scale. So we all agree, and should be known to all the students, that it is important to develop these non-technical skills also for patient safety. And besides the knowledge of the subject and the skills which we anyway gain during our training, it is important to develop these non-technical skills and the interpersonal skill to decrease errors and adverse events, especially in a complex situations and emergencies. Now, these interpersonal skills like effective communication, a good teamwork, and good team dynamics, leadership roles, and situational awareness and decision making can help us in long way. to become a better anesthesiologist. And that is what the residents needs to understand, that it is important to have knowledge as well as skill, but it is also important to develop these non-technical skills. So the Dr. Divya also discussed and the use of cognitive aids like checklist, decision making and protocols is important, and also the role of training or simulation is equally important to develop these. So we would like to know if there are any questions in the chat box, and all the speakers are here to address these questions. Are there any questions in the chat box?
No, ma'am, no questions as of now.
Any questions? Okay.
No questions in the chat box.
Yes, ma'am.
So I thank all the speakers for this wonderful presentation, and I hand over the mic to Dr. Baljit. Dr. Baljit is there?
And I'm very much there.
Yes, sir, Dr. Baljit.
Done to each and every
Thank you.
work, and got wiser with the great presentation that all the three speakers made. First, the one was technical and not technical skills and their interplay, which was very well highlighted by Dr. Ranju. I like the example 10 milligram and 10 ml, 10 of propofol. So that makes a huge difference. Just
That's an actual example from our ICU. You know, during the round, you saw one patient. I was there, and the concerned person just said 10 propofol de do. And the nursing staff interpreted that as 10 ml, whereas he actually meant 10 milligrams, which is just 1 ml. So it was given for a hypertensive response on to the ventilated patient, and resulted in a complete crash of the blood pressure within a couple of minutes. So a very clean example of how a simple miscommunication can lead to a disaster.
Very true. I generally give example of 15 milligrams of morphine. You know, the boss has said, okay, 15 milligram morphine, just to highlight the kind of the role of closed loop communication. So he is at 15. Sometimes the other person who perceives, he might say 50. So whenever such a thing happens, I think this should be mentioned. 15 milligram means 1.5. Okay. And the person who is getting the information or to whom the information is conveyed, he should say back, yes, sir, I'm giving 50 milligram morphine, that is 1.5 milligram.
Yes, sir. Closed. The loop must be closed. The loop must be closed.
Absolutely, very true. No denying that. Then Dr. Divya Jain, from theory to theater, the clinical applications. I like the statement where she said, these are the skills that make good anesthetist a great anesthetist. I think this is a very strong statement, and I fully endorse whatever she said. And the way she said it, the way she presented, I think this is very good. She presented a case, and thereafter she threaded each and every small thing which made a difference there. And then she also said that NTS is not optional; it is essential. I think that's another very good statement that one can always carry. These are small little things which always stick to your memory, and they're very, very significant. Then Dr. Akhil Kant Singh, he measured the intangibles, and by like his observable behavior and subjective impressions, I think that concept he made very, very clearly. And the last statement, of course, that was the cherry on the cake. What gets measured gets measured. I think this is a very, very important statement. Well, all the three speakers.
Sir, can I just take? So you have been in anesthesia practice for longer than most of us here. So have you actually seen a difference in anesthesia curriculum teaching over the years? Do you think we are actually making a difference? We're talking about NTS. So in the 50 years or 40 years that you've been around, whatever, more than each or any of us, do you think it has made a difference, or are we where we were a couple of years back?
Oh, I think it has made a lot of difference. I remember the time when I was a student. So we would the boss would say, okay, Kal, we'll discuss oxygen dissociation curve. So we'll discuss oxygen dissociation curve, that's it. See, now the teaching is more practical, it's more hands-on. Further on is that, the interaction between the students is encouraged. Earlier, the teacher would come, stand in front of the blackboard or whatever is there, and he would teach something, and the class is over, finished, not many questions asked. Although he would say that, okay, are there any questions? So, but the tone of the teacher would be that no one would dare to ask the question. But now students are smart. They do, even if they haven't come to the class after reading, they understand what is being said, and they are very open to, talking to the teacher with regard to clarifying their doubts. And it's more practical, more hands-on. That makes all the difference, because something that is said, you're likely to forget. Something that you do will always be remembered, always.
Thank
So
you.
thank you so much, three.
Sir, I also have a question. It the opposite way around. Instead of Dr. Sujata asking us questions, I also have a question for ma'am, because she's now on the other side of the table. She's been a clinician for so long. She's a very dear friend, but now she's become an administrator, and she's gone into the ministry to where she can actually influence decisions. She's in a very, very important post. And every time the clinician approaches the administrator with equipment that costs money, the traditional answer which I have been facing now is HOD is that इतने सारे मरीज हैं सिखाने के लिए, तुम्हें सिमुलेटर क्यों चाहिए, which costs a couple of crores. So that is the commonest answer whenever we want to buy expensive equipment for teaching, a simulator, for example. So the standard answer across the board is that you have millions of patients. Why do you need a simulator? So now that ma'am is on the other side of the picture, other side of the table, ma'am, what do you have to say?
So it's not like that, because we understand, and even in the administration, people understand the concept of patient safety, and everybody understands that if you learn on patients, it is not possible to learn on patients each and everything. And when we prepare and when simulate on simulators, we are actually preparing for any emergency situation which we can face, and then we are able to handle it in a better way. So with the NMC also coming up with the skill lab, and the simulation is becoming an important part of teaching and training also, and it is accepted. So that is why according to NMC also, the simulation lab has become, or the skill lab has become an important thing, or a mandatory thing for teaching and training, even for undergraduates. And for our postgraduates, because we deal with the specialty where we'll end up with emergency scenarios very often, like arrhythmia or so. When we are prepared, or when we are trained on, like now we are training our students on these simulators, so I think that will be preparing them to face this thing, rather than facing the situation in real life and then landing up with problems and learning by mistakes.
So ma'am, ये clinician बोल रहा है कि administrator बोल रहा है?
इन दोनों ही बोल रहे हैं. I am
Fabulous.
I'll be back to my clinical.
We are so absolutely glad to hear this. Thank you so much for these
I think
words.
we are just going away from the main topic. Well,
Yes, sir.
Right,
Sujata
right.
very, very nicely handled that question. This was kind of a googly for, from you. I think she very well handled. And I think she just about one chair away from, from being where her husband and very illustrious gentleman
Right, sir.
occupied that chair. We look forward to her going to that chair. And whatever she is saying today, I'm sure she'll do more than what's said today. She certainly will improve the conditions in all the hospitals. She has worked in GTB hospital, and then she has been in Safdarjung, and she has a big body of experience of
Yes.
working as a clinician, as a teacher, and all the roles that one can think of performing while you are in the chair. So thank you so much, speakers, and thank you so much, Dr. Sujata, for very, very ably and nicely handling the question answer session, and of course moderating the session.
Thank you so much.
Thank you, sir.
Thank you, everyone.
Thank you very
Thank you,
much
sir.
on
Thank you,
behalf
ma'am.
of President ICA, and of course on my behalf too. I thank all the speakers, and of course the moderator, Dr. Sujata Chaudhary. Look forward to seeing you again sometime on the same platform. Till then, goodbye, and wish you all the very best. Stay happy and stay.
Thank
Good
you.
night.
Good night.
Good night, sir.
Thank
Thank you.
you.
Good night, sir. Good night, ma'am.
And thanks
Thank
to
you,
all the
everyone.
dignitaries present here. Clarinet is really glad to have all of you here with us today. And again, thank you so much for giving us this opportunity to host a session. And I hope you all had a seamless experience. So,
Thank
with everyone's permission, I'm going to the session in
Thank
here
you
for
for,
today
thank
and
you very
looking
much.
forward to host you again. Thank you so much.
Thank
Thank,
you. Thank you.
Good night, Yashri ma'am.
Good night.
Good
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 night,
night.
ma'am.
night to all.
Thank you. Good night.
good night.